Good evening, everybody. Welcome to our TIF Talk this evening. I am your host, Wendy Profit from Endogastric Solutions. And with us tonight, I am pleased to introduce you to Dr. Dan Davis in Bowling Green, Kentucky. Dr. Davis earned his medical degree from the University of Kansas School of Medicine and completed his residency at Finch University of Health Sciences Chicago Medical School. He's board certified by the American Board of Surgery and serves as director of the Third Year Clerkship Program for the University of Kentucky College of Medicine at Bowling Green. Dr. Davis's clinical interests include hiatal hernia repair, GERD, and the endoscopic TIF procedure for reflux. He practices in Bowling Green, Kentucky at Med Center Health General Surgery and is affiliated with the Med Center at Bowling Green, the Medical Center at Albany, the Medical Center at Franklin, and the Medical Center at Scottsville and Commonwealth Regional Specialty Hospital. Welcome, Dr. Davis. Thanks for joining us.
Thank you.
So let's go ahead and jump in. We appreciate everybody tuning in. If you will, please go ahead, ask your questions for Dr. Davis in the comments section of our webcast. Let him know where you're from, and we'll go ahead and get to those questions as time allows. Thanks again for being here. So Dr. Davis, let's go ahead and start with, what is GERD? Can you tell us just about the condition itself, and then also what symptoms it includes?
So yeah, GERD is gastroesophageal reflux disease, which includes alkaline reflux as well, but it's reflux of gastric contents up into your esophagus. And so when I ask people about what their symptoms are, we'll talk about heartburn and when that's occurring in relation to what they're eating and what they've been eating that will cause the heartburn to occur. But I think most people kind of understand a little bit about heartburn. You get that pain in the middle of your chest. And then we also talk about the reflux symptoms. So some people will get heartburn and reflux at the same time and notice that sour taste in the back of their throat or gastric contents, or even some people explain it like it's kind of like a mini vomit, it doesn't come out, but the gastric contents come in the back of their throat. So we try to determine, which is more prevalent and when are they occurring, and those are the most common GERD symptoms.
Thank you. Any symptoms that are atypical that you see quite a lot?
Yeah, so other atypical symptoms would be most of the time it's silent reflux, where people may be having recurrent aspiration pneumonias. And the pulmonologist is like, we don't know what's going on. Why do you keep getting pneumonias? And they may do some workup and then find out that the people have been refluxing. And so what happens is the acid comes up, but they don't really feel the heartburn. They don't get the bad taste in the back of their throat. It can go into their lungs, cause pneumonitis, and then they get aspiration pneumonias. I've had a patient or two that also had some voice problems, and the ENT did the workup and then did the acid, like pH study, found out they were refluxing really bad, thought that might be related because they did their laryngoscopes and didn't see any damage to the vocal cords, and that can be another atypical symptom. I've had a patient that had a chronic cough, or actually a couple of chronic cough people, thought it was related to sinusitis, saw ENTs, saw a pulmonologist. Finally, we got a reflux workup done and found out they were refluxing. And so they would get a little bit of their gastric contents into their trachea, and then it would cause coughing fits. And those are some of the more atypical symptoms. But the one lady had real bad coughing fits. We found out she was refluxing really bad. I wasn't so sure that her coughing fits were completely related to a reflux, but we certainly did she had a hiatal hernia as well, so we did a combo hiatal hernia repair with the laparoscope and then the TIF to do the fundoplication from the inside. And her coughing fits are significantly better. They're not 100% cured, but she is so happy that she doesn't have those anymore. And more importantly, she didn't realize that she wasn't sleeping at night. And so I think sometimes poor sleep is reflux. You're refluxing while you're sleeping. You wake up and gag a little bit and go back to sleep. And you wake up and you gag and you go back to sleep. And she didn't realize it, but she said she has slept better since she's had the procedure than she has in like 25 years. Since she was in her teens, didn't realize it, but she's chronically tired, chronically not sleeping well, and didn't know that was the problem. Just thought that she's kind of puny, and tired all the time. Didn't realize that she wasn't sleeping because of her reflux. So it can be a lot of things for atypical symptoms. So
that's amazing. Wow. So what do you tell your patients who seek your opinion and evaluation about how they can manage their symptoms, manage their GERD?
Yeah, well, so we have some good medications, and I'll see what they've been on. Certainly famotidine, which is the generic version of over-the-counter Pepcid, is what most people start with. It's a good acid blocking medication. The proton pump inhibitors are the stronger ones that most people have heard about, such as pantoprazole. Well, I'll go through so omeprazole and Prilosec and Prevacid and Acifex and Dexilant and those sort of medications, Nexium and Protonix. Those work really nicely, and for years we were giving people those like candy. Because they work, and people didn't have reflux or heartburn anymore, and so, or at least it really controlled heartburn better, because if you're still refluxing, it's just less acidic. You noticed it with less, but controlled heartburn really well, but we found that those medications have side effects, and so. Especially osteoporosis is a big one, and especially for women, that's just not a good thing to be taking another medication that can make that worse as women get older. They're already at some risk for osteoporosis, but they found people on chronic proton pump inhibitor medications have increased gut infections. They have more kidney problems. They don't absorb vitamin B12 and magnesium as well, and various other things. It's not horrible rates, but they're not. It's not good either. And so, the medical profession has been trying to get people off of PPI since we've discovered some of these side effects. And really big push in the last 5 years, really, to try to get people off PPIs back onto Pepcid and those medications. And then also we did a lot of education about diet and activities. And so if you eat, if you don't eat fried foods and greasy foods and eat smaller meals and stay upright after eating instead of laying down or taking naps, avoided coffee and tea and chocolate and mint and that sort of stuff, that you can do better. You don't have as much heartburn and reflux. And so those are kind of the non-surgical things that we, talk to people about and been working with people for years. It's diet education, medications, that, as I mentioned, we've learned more about over the last 20 years. And we've been, like I said, just in the last 5 years or so, I've been trying to get more and more people off of PPIs. So I think I answered your question. But
you did. So. Thank you very much. So can you talk about some options that are currently available to treat GERD once people are past their courtship with their PPIs?
Yeah, so certainly I'll see people saying, tired of taking medication, or medications aren't working like they used to. I've been through 3 different ones or whatever. I want to talk about a surgical option, and especially when you hear about, if you have a small hiatal hernia, you may be able to just have the TIF procedure. Use the endogastric solutions device over the gastroscope, no cutting, fantastic. You can get your reflux controlled and do a fundoplication from inside just using a gastroscope. But for when I was in training about 20 years ago, Nissen was the definitive surgery. You did a laparoscopic hernia repair. You did a laparoscopic fundoplication where you wrap the stomach around on itself, which means you have to free up a bunch of tissue around the stomach. It deforms the anatomy of the upper part of the stomach. There's some risk involved with possibly poking a hole in the stomach or esophagus or injuring the vagus nerve. But anyway, that's what we were doing. But over the last, since I finished training for about 15 years or so there, the number of Nissens had decreased significantly. And there's data behind that. It's just that surgeons weren't as happy with the results. Any fundoplication or any anti-reflux procedure doesn't last forever. It's just the way it is. You have to have food going down through your esophagus, and it will loosen up with time. The hiatal hernia repair can loosen up with time, and so then you're doing another surgery, and so the Nissen is a difficult surgery to redo. Actually, one of the surgeries we as general surgeons probably like the least is doing a redo Nissen. But if you do like, anyway, I'll talk a little bit about the combo procedure. If you have a hiatal hernia and you're having reflux and you want to have a procedure, you should have your hiatal hernia repaired if it's bigger than 2 centimeters. The data says that you will have much better reflux control. They've done all those studies. So you have to fix the problem where the stomach's sliding up into the chest, and you can only do that with the laparoscope if your hiatal hernia is over 2 centimeters. And a lot of people have ones that big. So you can do laparoscopic surgeries, 35 to 45 minutes. If somebody does them a lot like I do. So anyway, you bring the stomach out of the chest, you tighten up that diaphragm defect, and that now is fixed. Like I said, for now, right? It'll last 7, 12 years, 15. We don't know. Depends on you and your weight and how active you are and stuff like that. But it will stretch out eventually, probably. But it may last a very long time. So, and then you can do the fundoplication. The fundoplication is also necessary to help decrease you from having reflux. So what it does is it reinforces the sphincter muscle, which then will keep acid in the stomach better. And so the ways to do that, you can wrap it with the Nissen, where you do a 360-degree wrap around the stomach. But like I said, there's some side effects of that. There's some injury risk. The main thing is that 40% of those people have gas bloat, which is miserable. If you can't burp and you're full of gas, you feel that some people told me it's worse than their reflux was. Well, that's not pleasant. And so I think that's part of the main reason why people do less and less Nissen fundoplications is the gas bloat complaint is significant. Whereas if you do the fundoplication from the inside with the TIF, where you just got the device with the gastroscope and you're reinforcing that sphincter muscle by forming the fundoplication is the word we use, but it's basically creating a little flap there on the inside of your stomach with the gastroscope, then you don't get the gas bloat. And it's actually the safety rating for that procedure is extremely high. You are not going to be poking holes in the esophagus and the stomach. You're not going to be injuring the vagus nerve. And if eventually that stretches out, you can just go back in and reinforce it with the same device. Well, not, same procedure. The device has been in the trash, right? You have to use it. But anyway, the same procedure. So I just found that to be when I first learned about this. This has been around since 2008. And I remember hearing about this. I was at a conference in St. Louis, and I thought that's brilliant, but it wasn't approved. They're just, kicking around the concept and doing their studies and stuff. And I said, well, I can't do that where I'm trained, where I'm working at right now. But then when it got approved through insurance and through Medicare and Medicaid, then I became interested. So I was like, well, they've got the studies down. We can do it even in Bowling Green or, wherever you're at. And so that's great because now I've got a procedure that I can do very safely and give somebody a fundoplication without the gas bloat. And it's much safer. I shouldn't say much because the Nissen's pretty safe, but it's safer than the Nissen. And I can redo it if I need to in 5 years, 10 years, 15 years, so that's fantastic. One of the things that was difficult, if you were a younger person, you had really bad heartburn or reflux, a lot of surgeons in the past didn't want to do any surgical intervention because, if you're 25, we're going to have to redo it when you're 35 or, let's give it 40 maybe. It maybe lasts 15 years. Now at 40, you have to go do a redo. Now 60, it's going to loosen up again at some point. These things don't last forever. They just don't because of the way the anatomy is. It's not like a hernia in the belly button where I put a patch on the hole. that's fixed, right? The esophagus still goes through that hole. You still have to have food pass up, through there 2 to 3 or 4, some of us many more times a day than that, and so it will stretch out over time. And so at some point, if you're young enough and you get your surgery, you're going to have a reinforcement or a redo at some point. But if you do the TIF, you can go and just have another gastroscope, reinforce the weak areas. You're good. Maybe another 7, 10 years. That'd be fantastic.
I'm so glad you touched on that, because we get questions usually on a weekly basis as we do these broadcasts about, redos, what the need for them typically is, and what that situation looks like. So thank you very much for touching on that.
Yeah, I think it's a really important part. It's a really important part because gastroesophageal reflux disease is it's not taking your gallbladder out. If you take your gallbladder out, you won't have any more biliary colic episodes or gallbladder attacks. It's done. But when you have acid reflux disease, when you do a anti-reflux procedure like the TIF, 70% of people can get off their acid blocking medicine and eat whatever they want again. That's fantastic, but that's not permanent. If you live long enough, it will probably weaken and you will have some symptoms again. So you have to think ahead of that, and so if in let's say last 15 years, great. Well, I just go and reinforce my previous fundoplication. We're good, so.
Excellent. Thank you. So what I'd like to do is turn things over to my colleague, Lynn, who is waiting in the wings with some questions. Lynn McFadden, thank you so much for being here with us tonight. What do you got?
Thank you, Wendy. We do have some questions from the audience, but Dr. Davis, you've done such a great job of covering a lot of the questions we typically receive. So some of these might be a repeat, but it never hurts to hear it twice. What kind of tests do I need to have prior to a TIF procedure, or how do I know that I'm a candidate for the TIF procedure?
Okay, so we'll do the candidate first, I guess. So basically, somebody that has been proven to have reflux. So you can prove that in various ways. You can do a pH study. They put a little device in the bottom of your esophagus and it stays there and registers how much acid comes up and how often and all that stuff. You do a little diary, you keep track, and if your symptoms seem to correlate when you have acid coming up there, then that proves you're having bad reflux. And then, so that, I'm sorry, I think I got a little distracted. But anyway, so that's one thing that you can do to try to determine that that's the cause of your symptoms. Another thing you can do is a gastroscope. You really should have a gastroscope done by the person that's considering doing your anti-reflux procedure. They need to see it themselves, see how big the hiatal hernia is, see the distal esophagus, and is it very irritated? Is it going to hold the little fasteners and the little device that we use to pull the stomach down into the fastener deployment device? They need to see that. So even if you've had a gastroenterologist scope you like 2 months ago, and they're you're just tired of PPIs and following a strict diet, you haven't drank orange juice in 20 years because it messes up your gives you heartburn every time. And so you finally see a surgeon about it. That surgeon really should look and take a look at the anatomy himself. So anyway, so if you've proven that they have acid, and symptomatically it looks like that's the problem, you may need further studies. It all depends upon your esophageal function and also how well your stomach empties. So we'll ask a bunch of questions about that helps us with that. So the main thing is about dysphagia. Does food ever seem to stick as it goes down? If that happens, you should have further workup for that, either a manometry or start with maybe a esophagram. But the manometry is probably the best study for that. But people don't like that very much because you have to have a little tube in your nose and it checks the function of your esophagus. There's another device that some places have that works just as good, and that's fantastic if they're going to check your esophageal function with that. But if your esophageal function is diminished, that may affect how tight you get your wrap done, or even if you're getting a wrap. So I've had a few people with extremely dysfunctional esophaguses. You have to tailor the procedure to what they have. And so, if I'm doing any type of fund application down, in there, I can't see myself anyway, down here. I'm trying to look in the camera and see where I'm at on the screen, but you know, if I'm reinforcing that sphincter muscle and making that tighter, but their esophagus doesn't squeeze and, you know, and push food down their stomach very well, then I've made things worse. You know, their esophagus is going to be full up with food all the time, and that's horrible. You know, aspiration and stuff. So you have to kind of, you know, take a good history and see. So if people are saying sometimes food gets stuck, well, sometimes that's esophageal dysfunction. Sometimes it's just their hiatal hernia is big, and when food goes down, it's not a straight shot. It hits the big hernia coming up and pushing up against their food, you know, the food coming down. And if we straighten that out, that'll fix it. So you have to kind of determine that. That may require more studies. So maybe babbling on a little bit too much. But anyway, I'm just trying to, so there may be other studies that need to be done. Some of those can be very important because in diabetics, sometimes they will get gastroparesis. So if I'm finding symptoms, you know, when I'm doing my history of it sounds like their stomach's not emptying well, then they may get a gastric emptying study first before I do any fundoplication or even before I can do a gastroscope. Because maybe their stomach doesn't empty real well. That's important to know because they may have some trouble with the procedure, because if they don't empty well from the bottom and I'm tightening up the top, you know, they're going to have to watch some diet modification, or, you know, we may have to do something to help the stomach empty better, or they're going to get all full and bloated and feel like the Nissen people do. So, so there may be various different studies that have to be done depending upon your history, and they may not do any fundoplication. I had a patient who had a very large hiatal hernia for many years. His esophagus had dilated up to about 5 centimeters in diameter, was totally non-functional. I couldn't do any fundoplication on him. His esophagus is just a tube. The only way that food goes down is with gravity. There was no squeezing with it whatsoever. So we fixed his hiatal hernia. He has to watch a very special diet. He doesn't want to go see somebody about making a new esophagus out of his stomach, or, you know, colon, all those sorts of crazy big surgeries. He just wants to eat some soup and Jello, and he's much happier now because food can actually go down, where before it was getting stuck at the hiatal hernia. But some people have very difficult problems to take care of. So anyway.
Thank you. No, they're great answers to those questions. And I think the best point is that you just made is every body is different. So it will be dependent on each person as to what kind of tests happen and the recommendations that follow. There was another question here that is, I guess, along those lines from Jason. He's asking about how many times in a lifetime actually fasteners can be placed, and does that lead to some risk of any kind of esophagectomy in the long term?
Yeah, I don't think there would be any risk of an esophagectomy from recurrent fastener use. Of course, the procedure's not been, you know, with putting the fasteners in the distal esophagus hasn't been around long enough to know, but I don't see why that would lead to, you know, any reason to get an esophagectomy. And then as I think, as far as, I mean, I guess we don't know exactly right now. I know that there's been people that have done redos. The procedure's been out for more than 13 years, right? Yeah, 13 years. And there's been, how many now are we up to that have done?
About 27,000. Yeah.
27,000 patients. So I know some of those have probably had, you know, another set of fasteners placed. I don't know if anybody's had a third set or not, but I wouldn't think that there'd be any, because the reason that you would need to do an esophagectomy would be if you were causing chronic scarring. Sure. Or changes to the distal esophagus that would lead to precancerous conditions. And actually, by doing the fundoplication, you decrease how much reflux is going on, and you're decreasing your long-term risk for esophageal cancer. So actually, by doing it, you're decreasing that as a possible reason to eventually have an esophagectomy. They have studies that show that fundoplications significantly, the rate's not real high, obviously. People with Barrett's and chronic esophageal injury don't get esophageal cancers at high rates, but it's higher than normal people, you know,
Sure.
that don't reflux by a significant amount. But if you can keep the acid down with the acid blocking procedures, then you decrease their risk for esophageal cancer to almost zero. So you take that risk out. Also, the reasons that some people will get esophageal stenosis, which can be a problem if you want to have, you've been having bad reflux, it's been damaging the bottom of your esophagus for years, and now it's really narrow, and you go in and they dilate it a couple times. If you can't get it up to a certain size, you can never have a TIF procedure because you can't fit the device through your scarred up esophagus. I didn't bring that up earlier, but that would be a reason why you can't have the TIF. If your esophagus has got too narrow of an area and you cannot get it stretched up to a size that you can actually get the device in, you can't do a TIF on that person. But I have not seen or read or heard, and I don't see, you know, how that would cause stenosis of the esophagus with repeated fastener applications. I guess it's not impossible, but you're actually, by doing your fundoplication, which your fasteners are involved with that, are decreasing how much acid's going up into your esophagus and decreasing your risk for getting esophageal stenosis. So, yeah, I don't think you'd have a very high risk for a esophagectomy just because you've had a couple sets of fasteners placed over your lifetime.
Thank you.
But you don't have any studies that, who would know? I mean, yes, in 50 years, maybe we'll know, but I don't see that would be a high rate.
We get a lot of great questions, so thank you very much for answering that. Wendy, do you want me to ask a couple more? Or?
If you have any more that you'd like to, we can go ahead. We do obviously want to get into, you know, just what recovery looks like. So I know we have a couple of questions about that. And Dr. Davis, if you've seen me looking this way, it's just because I'm watching the feed. We have a lot of great questions. So I
try to look this way.
Yeah. So thanks to everybody for you know, sending in your questions. But yeah, Lynn, if you have anything else you want to throw in there right now, let's do it. Actually,
the next question I was going to ask was about recovery. We have a couple about food and regurgitation. I'll ask that first. Is big food regurgitation mainly a symptom of a hiatal hernia? And can just a hernia repair work with mesh?
So a hernia repair with mesh can work if you have a good functioning gastroesophageal sphincter. Hernia repair without mesh also works fine. I don't like using mesh personally because you can have erosion into the esophagus. It's pretty scary when that happens. So anyway, sometimes it's necessary to use a mesh. I really try to avoid it as much as I possibly can. Because of those risks. And of course they have meshes. If you're asking the question, you probably know they have meshes that are considered permanent and other meshes that are biodegradable. The biodegradable ones, of course, go away eventually. They just break down. But anyway, we were talking about, what was the first part? I just wanted to talk about the mesh there for a second. What was the other part of the question?
Can just a hiatal hernia repair work? Is food regurgitation a symptom of a hiatal hernia? And I think you covered that earlier.
It can be esophageal dysfunction because the esophagus never really clears and it just comes back up. Some people have esophaguses that not only don't squeeze going down very well, but they squeeze the wrong way, you know, part of the time. So it actually pushes food the wrong direction. Poor gastric emptying can cause that. Like if your stomach's always full because you have gastroparesis from diabetes or some other, you know, issue, then yeah, you can get food coming back up fairly regularly. Also, if you have a hiatal hernia, it's usually bigger ones, but if you have a big hiatal hernia where the food gets in out of the esophagus into the upper part of the stomach where it's trapped in the chest, it may stay there for hours and never drain into the rest of the stomach. That will possibly come back up through your esophagus into your mouth before it goes down into the stomach, and that's miserable. Those certainly people with big hiatal hernias or a paraesophageal hernia, you can look it up. It's slightly different, but those need to be fixed. They're just a higher risk for aspiration. People can start feeling not so good. Most hiatal hernias just slide up and down and give you heartburn or reflux. The smaller ones, less than 6 centimeters probably. The big ones, where your stomach's always in your chest, that can feel like you've eaten a balloon and never goes away. And it just sits in your chest and feels awful. And those we move on a little quicker, but we do need to work up and make sure that their stomach's emptying well and that they got a good esophageal, function. But yeah, we move along on those folks because they just got food sitting here all the time. It could come up and they could aspirate at any moment almost. So
very uncomfortable.
Yeah. You're asking about recovery. Yeah. So all right. So a lot of people have hiatal hernias that have heartburn and reflux. And if it's bigger than a certain size we just talked about, you need to have it fixed as part of your procedure. And so those folks definitely need to watch their activity level and not do a lot of lifting, pushing, and pulling and strenuous activity. I usually say at least 6 weeks, give it plenty of time to heal and scarring well. And they also, anybody that has any fundoplication procedure needs to follow a diet. The Endogastric Solutions has a really cute little patient instructions sheet right here. It's great. Has a thing in the middle that goes through the diet. Ask your doctor for it. It goes through examples of what you should eat. In the first 3 days, they say like a clear liquid diet, and then you go to a full liquid diet for up to the 14-day mark. And at 14 days, you can then start eating soft foods that you can squish up with a fork. So one of the surgeons told me when I started doing this, he tells people that for the first 2 weeks, anything that'll fit through a straw is okay. Now, don't use a straw. If it would fit through a straw, that's what you can have. And then for the next 2 weeks, anything you can squish up real good with a fork is okay. And the reason for that is your fundoplication is going to be a little tighter for the first few days, especially, but the first few weeks, than it will be the rest of your life because it swells. You've done surgery. Anybody that's had surgery knows there's swelling. And so there'll be some swelling. It'll be a little tighter. And so you want to stay, with good nutrition. So you need to be able to follow the diet so things will go down, And then after that, you just add in foods as you feel. I've had some people go faster, some people go slower. It all depends upon how you are doing with the diet. And then the last things you add are like steak and pork chops and dried breads. Dried breads tend to stick on the way down a little bit. That's often a first sign of dysphagia. So if you're eating sandwiches and food's not going down so good, and you're seeing your surgeon and talking about reflux, you want to mention that to them if they didn't ask, because that's maybe a sign that your esophagus is having a little trouble. Anyway, that's just a sidebar. So let's see. So we talked about the diet. The diet is a big deal because you think about 2 weeks of just liquids. That's not normal. So you probably will lose a little bit of weight. Most people do, as they're following this diet and in their recovery period. Let's see. And then hopefully, it depends, but between 6 and 8 weeks, hopefully you're eating everything you used to eat. So, and certainly, people that do anti-reflux procedures here, people pretty excited about, I can now drink orange juice. I haven't drank orange juice in 20 years because I always got horrible heartburn after, drinking orange juice, but now I can. That's fantastic. That's very exciting. That makes me happy. Or, another patient told me I can have spicy tacos. I love them, but I can't have them, but now they can. So that's pretty cool. That one lady I was telling you about that had the bad coughing fits, she's sleeping at night better than she's ever slept. And I didn't expect that. She didn't either, but that's a fantastic find that, she's better now because she was waking up at night with reflux and didn't realize it. So, you can have a big improvement in your life with this procedure, depending on your symptoms and what's going on. So, okay.
Wonderful. Lynn, any other ones before I take back over, or?
It looks like, Dr. Davis, again, you've done such a great job on these questions. You've answered most of them. One, you answered, why does bread get stuck in my throat? This is one question we have. So you touched on that. Another person is commenting that it sounds like a very safe and effective procedure. This one here, though, what else can cause LPR if you don't have GERD or reflux?
What LPR? Sorry.
Yes, sorry, I have to turn to see my screen as well. But what else could cause LPR if you don't have GERD or reflux?
Tell me what LPR stands for. Maybe I'm stressed on TV. What is it?
It's
Pharyngeal reflux.
Oh, all right. Pharyngeal reflux. What else can cause that? Oh, that is difficult. It's probably the bane of the ENT's existence, right? People come in and they say they feel like they're getting stuff stuck. They call it globus sensation. We don't know why that is sometimes. So people will get, quite a bit of workup sometimes, a manometry, a esophagram. The esophagram is where you actually swallow the stuff and they watch it go down on x-ray. And manometries, we actually go in and test the muscle squeezing as it goes on, either up or down, whatever. And some people will have normal studies on that, and they still feel like things are getting stuck. And the ENTs scope them, they can't figure it out. I'll do it. They'll send it to me. I'll do a scope. I'll put a balloon in there at the biggest size I can just to see if maybe it's narrowed and we can't tell. And I've had a few people get a little better sometimes when you go in and stretch and get those muscle fibers kind of broke up, and other people have no benefit. That's a tough one. But some people do. They get these laryngeal aspiration things, and it's not reflux. And I don't think that we have a great answer. Sometimes we do a whole bunch of workup, and you'll see often an ENT, of course your primary doc, usually an ENT, a surgeon or a gastroenterologist or both, and you still are like, this stinks, I want an answer, and sometimes we just don't. They call it globus sensation. Sorry, I don't know what's going on. You get this sensation. It feels like stuff stuck there. And sometimes, you're getting actual real stuff in your lungs, and we don't know why that's going on or where it's coming from. It could be sinus problems as well. It's actually coming from above and draining down and just not going into your esophagus. You're getting it up into your airway instead. Maybe you're not protecting your airway well from some sort of epiglottis problem. It's a difficult problem. That's a very good question. I wish I had a good answer for you.
You get a great answer, and thank you for covering that. Wendy, I'll turn it back to you.
Okay. Well, thank you very much. We've covered quite a bit. Really appreciate all of the information. This is the first time I've actually heard anyone discuss diabetic patients and the considerations that they have to take into account when they are seeking treatment, and really appreciate you touching on that. When we talk about folks who are post-procedure and now they are looking forward to living GERD-free, the two biggest things on their mind, and you've touched a little bit about on both of these topics, but are obviously number one, diet. You touched on post-operative diet and then what things can look like further out. A lot of folks are also very interested in physical activity because they describe things that they couldn't do prior to having some sort of corrective treatment. Are there things like that people describe to you often that they're unable to do without suffering symptoms that they're able to do later on?
Yeah, the main thing is people have had some people with really lax gastroesophageal sphincters that every time they bend over, they reflux. So that's nice to be able to bend over and get, tie your shoe or get something from underneath the bed without, your breakfast coming back up into your mouth, I just bring that up. But as far as like physical activities, I don't know what they'd be referring to.
I've heard bike riders, folks who, and to
Yeah,
your point,
that's true.
Obviously it's posture driven, right?
You're right. Yeah. So you're going to have more trouble if you're wearing tighter clothes or if you're doing the leaning forward, which you're right, bike riders would have trouble with that. Yeah, any anti-reflex procedure would help you to be able to return to those sort of activities because that's going to be tighter at the top now. And so it'll be, even though you're still doing postural things that would be forcing pressure up to that diaphragm, because it's tighter, you will get less reflux going on. I tell people to go ahead and resume whatever physical activities they would like to do. And I guess I haven't had any hardcore bikers come through, but that certainly would be, yeah, absolutely. You're leaning forward, you're exerting some muscles, and that abdominal pressure as you're leaning forward is going to increase and squeeze your stomach more. I would hope that, if you had a nice recovery and if you had a hiatal hernia repair that healed well and your reflexes, your anti-reflux procedure is nice and tight, that you would be able to do that again. We'd have to ask, maybe that's a good question for one of the docs that's done a few, thousand of these. And see what
Excellent.
Any professional bikers on their list of patients. I don't know.
Anything you tell your patients you don't want them doing after a TIF procedure into perpetuity? I mean, are there any high-risk hobbies? Are there any things that you'd like them to steer clear of?
Yeah, I think probably really strenuous lifting. If you're a really serious weightlifter, that'd probably be a bad thing. It'd probably stretch out much sooner. I think that would probably be the worst thing, actually, more than bike riding or anything like that. Because when those people are lifting amazing amounts of weight, and you're using your core for that. And anytime you're increasing your abdominal pressure that much, I think your hiatal hernia repair, your fundoplication are going to have some trouble. For fundoplications, probably overeating. You don't want to keep your stomach really full all the time. That's going to put a lot of stress on your repair. It's best to follow a good diet for, like I said, at least 6 weeks. But honestly, longer is better. If you can eat smaller meals and follow a good diet, not only is it just healthier, I think you're giving that fundoplication a real good time to heal up well. Because when we do the little fasteners, those aren't providing you permanent strength to the fundoplication. It's keeping things in place so it can scar. So your body can do its work and kind of scar and form a tighter area around that sphincter muscle is needing some assistance. So anyway.
Thank you. All right. Well, we're coming down to the end of the program. We typically wind things up by asking our guests, if you have any parting thoughts, words of wisdom for those out there who are suffering, who are a little unsure about what to do next.
What was the last part? A little unsure of what to do?
Who are just suffering from symptoms and are just wondering what to do next. What are their options?
Yeah. I would say, do some research, find, a surgeon, near your community that's doing the procedure, a gastroenterologist. Obviously, there are lots of gastroenterologists that are doing the TIF part, and then, if somebody needs a hiatal hernia, they have a surgeon do the hiatal hernia part. Because I think I got excited about it because of the safety rating. Honestly, I think this is a very safe procedure. This is a procedure that I know will eventually loosen up if you live long enough. And I have a good option. I can just do another fundoplication or reinforce weak areas. So as a surgeon, I find this is very beneficial, and you get the same outcomes. Look at the data from the Nissens, look at the data from the TIFs. Same number of people get off PPIs, same number of people, do well. It's fantastic, and it's a very safe procedure. So that's why I like it. But gastroenterologists certainly have people come to their office all the time with these complaints, right? Heartburn, reflux. For years, it would just give people medication, pat them on the back, tell them to follow a diet, move on. So some gastroenterologists are doing these procedures because they're just happy that they can do something that will help, So I think that's the main thing, find somebody that's engaged, has been doing these procedures, and then they, can tailor what you need. Because like I said, everybody's just a little bit different, and I don't do the same tightness on every single patient for the wrap. Some patients don't get this or that because they have gastric paresis or their esophagus doesn't work very well or whatever. And so, it's not a one thing fits all. So I think you've got to give, somebody that you have done some little research on and you trust. So anyway, I think that's what I would do.
Well, thank you.
And there's
for
plenty. There's lots more and more people are understanding. More and more surgeon gastroenterologists understand this procedure. So I think you got more people to turn to now than you did 5 years ago or 7 years ago.
Yeah, excellent. That is so true. Well, everybody, if you are in the Bowling Green, Kentucky area and looking for expert care, Dr. Davis is in the market and would be glad to see you. We also have a GERDhelp.com physician directory if you are not in the Bowling Green area and are looking for an expert on TIF. You can jump on GERDhelp.com, look in the physician locator, enter your zip code, and find a doctor in your area. We also just launched a patient education app, GERD Help, if you are in the Apple App Store or in the Google Store. It's also available on Android, and we'd love for you to download it, and hopefully it will help you in your journey. Dr. Davis, it's been a pleasure. We are so glad you could be with us tonight. Appreciate all the great info. And everybody, we will see you next Tuesday for another TIF Talk. Until then, have a great evening.
Excellent. Thanks.
Thank you.
Appreciate it.